notice till 10:45, and we're going to start with a call to order. Or can I just say that the two of us are here?
Yeah, you can say two of us.
Okay, in attendance is Daniel Boland and Karen Bronga, and no one is on the phone at this time. And do we have any unfinished business? I believe we do not have unfinished business, so we're going to go right into new business, and we have Julia Louie with VOA that is going to kick us off. So
Awesome.
take her away.
Thanks for having me. You can hear me okay? It's green, so I'm assuming yes.
Yeah.
Okay. My name's Julia Louie. I'm the president and CEO of VOA Alaska. We are a nonprofit behavioral health organization that specializes in the therapeutic services and supports for youth, young people, and their families. We have a beautiful mission, vision, core values, but really when you boil all of those things down, the reason why we exist is to eliminate suffering that has been exacerbated by substance use and mental health challenges. We have a robust continuum of care that really spans the intensity of services that align with individuals' healing journeys. And so we have a lot of beautiful effort that goes into our community coalition that really brings stakeholders to the table to really start putting some solutions to combating the substance use challenges that we have in our area. In addition to prevention, education, outreach, and engagement to youth, young people, and their families. And then we have different levels of intensity within our community-based outpatient programs that can be as little as 1 hour a week all the way up to 20, 30, 40 hours a week. The day treatment program that you see there on the continuum map is one of our newer programs that really serves as the bridge between residential programming and outpatient programming. And we're incredibly fortunate with the partnership with the Anchorage School District. They provide a teacher in both that environment and our residential treatment that is located in Eagle River. Our residential treatment center serves youth from all over Alaska. We are the only non-tribal residential program providing co-occurring substance use and mental health services to youth. We also have a supportive housing program that specializes in providing a housing first approach to transition age youth. We have a strong partnership with Covenant House in supporting the youth in her facilities and continuing to try our best to provide wraparound care for people's healing process. Then our peer support and family services are available to support youth, young people and their families, the entire continuity of their care. And so we firmly believe that in order to best serve those who come to us, we need to have a continuum of care that supports them through that transition of their healing journey. Wanted to hone in on impact of ARPA and alcohol tax funding. In calendar year 2023, the municipality has invested or committed to investing just under $1 million in VOA school-based and access and engagement programs. Let's see, through alcohol tax funding to our access and engagement, we've offered 120 engagement activities to an estimated 1,100 youth from January to September. These activities range from small indoor recovery-oriented activities, painting classes, large community events such as a barbecue. We had over 600 attendees, and here in just a couple weeks, we're doing a free open community event of ice skating. From these events, we had a good number of previously enrolled or people enroll in VOA services or referred to treatment, with an additional 468 touch points with youth enrolled in treatment services who have participated in one or more engagements throughout the year. The purpose of this funding is to create more inclusive pathways to care and support youth in their community to build up those positive support systems. Those protective factors we know are really what's going to help kind of change the tide in early upstream intervention to prevent further suffering down the road. The funding also supports personnel included in our rapid response team, specifically a mental health clinician whose role is to deploy to the community, to the schools, to the hospitals, to the shelters, to the homes, to really provide that initial conversation, connection, and navigation to needed services. The alcohol tax funding for our school-based services, it has allowed VOA to offer brand new trauma-informed summer camp for rising sixth graders at Beggage Middle School. This is a community that has experienced a tragic number of losses in recent year. Um, it's paralyzing the amount of trauma this school community has gone through, and so through the support and the investment of the assembly, the municipality really coming together and developing the summer program to really support sixth graders as they're really walking through that transition into middle school and really trying to again change the tide in some of these crisis situations that consume our schools and families. A notable success of the camp was the ability for these rising sixth graders to form friendships and connections prior to starting school. It was really sweet. At the end of camp, they asked a group of the students hanging out if they knew each other when they were coming through the camp because they just got along so beautifully. And they said, no, these are my new camp friends. And so just setting kids up for success before they move into that phase of uncertainty for so many of them. The ARPA 2 funding has had a huge significant impact on the growth and financial sustainability of our school-based program, which has grown from 4 schools in 2018 to 11 schools in 2023. Some quotes from the surveys that we do every year from school staff. We have a quote, once students and staff have the emotional mental tools to deal with their personal trauma, they can really start engage in their schoolwork. Our clinician has a positive impact on all students at our school. They've helped 4 of my students, and difference in their behavior from the beginning of the year to now is incredible. And we have had a kiddo say, not giving straight answers or solutions, but guiding me into finding what works for me to figure it out on my own. In terms of impact, we have 82% of school staff agree that on-site mental health services has had a significant impact on student academic performance. 97% of elementary and secondary students stated that my counseling services helped me deal with my problems, feelings, or situations I had when I started services. And 100% of caregivers stated that our family has had an increased sense of connection since beginning services at Providence and BOA. So diving into the youth mental health and substance use needs, it's important to really stay grounded in very concerning statistics that I know none of us are proud of, but it is the fact that we are #1 in the country for youth suicide, and the leading cause of death is suicide for those ages 15 to 24 years old. And when we really kind of boil that down, that's an average of 54 years of life lost for every young person who's dying by suicide. We're seeing client acuity and instances of self-harm and suicidal ideation we've never seen before. I think Allison will likely share more about what she's seeing at Covenant House. Reports of prior abuse have skyrocketed, increasing over 550%. Before COVID, PTSD was not one of the main diagnoses that we treated at VOA. Now it is in the top 3 diagnoses that we treat. And fentanyl, it's everywhere, and unfortunately, the fear feels like it's dissipating a little bit. And with teens, we really have to remember that they have a low ability to really conceptualize and think things through with that high impulsivity and that invincibility factor due to the undeveloped prefrontal cortex. So we're seeing that even though they don't know that this is what they're buying or they're getting, there's a sense of carelessness that we're seeing right now that needs some real wraparound support to address. In our prevention department, we partner with stakeholders all across the Anchorage area in providing naloxone overdose kits training to make sure that our partners and community are equipped with the tools to try to reverse an overdose if it happens on their watch. I thought this was something that we wanted to share. This is for those enrolled and engaged in our substance use treatment programming, this is the frequency that fentanyl is showing up on UAs. And like you can see, what we're seeing here is pretty sporadic. The spike that we see in the spring, summer of 2022, it's interesting. This is right around the time where we were really getting that new program that I spoke of earlier, the day treatment program, really dialed in and getting into stride. And so, again, that program is the bridge between residential and outpatient program. And we saw a significant decrease during that time, which is great. And we haven't seen a sharp increase like that since. So that tells us we're doing something right. We're on the right track. But again, it's everywhere. And as a provider, it feels like youth are becoming a little bit more immune to the fear of fentanyl. We've even tested for different types of substances, but include fentanyl because of the risk of it contaminating other substances. And youth and their families are very surprised when they find out that fentanyl was in the cocaine that they were taking, or barbiturate or Xanax, so on and so forth. It's in everything. I wanted to include this graph because I completely recognize and sound the alarm bells on the fentanyl crisis that we have on our hands, but we have a wave that's coming with xylazine. And so you will see that xylazine, it is being used to cut heroin, fentanyl, to really prolong and enhance the euphoric effects. Nationally, 16% of fentanyl-positive specimens contain xylazine. It's an animal tranquilizer. That's obviously not intended for humans. It has a flesh-eating effect, creating hard-to-heal wounds. And this isn't an opioid. So when someone is overdosing and the substance has been contaminated with xylazine, it's not reversible. It's also not an illegal drug, so it is creating a gray area. Of course, heroin, fentanyl, things that it's being cut with are, but we're seeing this spread across the country, and it's something that we need to be mindful of. If it's not already here, it will be. I wanted to hone in on Medicaid challenges. I know that I've had a few conversations with Assembly members about this specific topic. We have had a staggering number of youth lose Medicaid coverage due to the redetermination process. Just last month, this doubled. We're seeing huge disparities between adult and youth services. And oftentimes when you look at Medicaid services, rates, regulations, it really looks more fitting for an adult setting. And it's important to understand that in an adolescent programming, we're required to abide by childcare licensing rules and certain staffing ratios. And so we oftentimes require twice as much staffing than an adult provider. What should the client journey look like? If we only provide what is sustainable and reimbursable today, we will never end the youth mental health crisis. And I think that's something we really have to kind of hone in on and continue advocating for solutions around. When we think about what someone's journey should look like, the Assembly's investments in those earlier upstream activities is supporting those non-reimbursable services. That is the right work. However, there is no sustainability metric to maintaining those critical services. And so I know this is a little hard to see on the screen, but we have them in all of the flyers here too. We know that system-wide needs, referral coordination with other providers, startup costs for enhancing data collection reporting, all are not available under Medicaid. When we look at outreach, phone call or referral, screening, assessment, there is either no reimbursable services, or they are at such low rates or have strict rules and requirements that we aren't able to provide those. And so I'll hone in on the prevention, early intervention for schools, shelters, and hospitals. This is funding from the Assembly that we've received to provide that rapid response to deploy to the shelters, to the hospitals, to bridge the care that's needed to support these individuals. It's a really interesting statistic that kiddos that are in the hospitals, when they're discharged, only 30% are being connected with a community-based provider. And it's a question we have to start asking ourselves: why don't we have more community-based providers? It's because the mechanisms to support this work either exist at rates no one can build a business on, or it just simply, the service is not there. Again, Services delivered in correctional and medical institutions are not reimbursable under Medicaid. Housing or tenancy supports, such as for houseless youth or victims of trafficking, there are very little services that are available for this population. Years ago, we had a clinician who was embedded in Covenant House's Youth Engagement Center. And when we're working with a transient population, it's very difficult to walk through all of the paperwork processes that enable us to bill for Medicaid. And so we weren't able to sustain a position in the facility. Do we need a clinician in the facility? Yes, we do. We need a couple of them. But we can't make those decisions without other funding support plugging those holes as Medicaid services exist currently. We at VOA, I mentioned earlier, and I know I don't want to take too much more time. We believe in doing the right work and really rallying stakeholders and supports to fund this critical work, but we're struggling. We are struggling to maintain the services that are important without long-term sustainability. And the residential program that we operate in Eagle River is one of the ones that is an adolescent provider stuck in an adult system of care. And if something doesn't change soon, we're going to have to really make some tough decisions about what that program offers in the long term. Again, in summary, we are over the moon appreciative of the investment made by the Assembly to fund services that are essential and critical to filling these gaps. As a youth behavioral health provider, I will say that I am deeply concerned. The needs continue to rise, the rates have hardly shifted, and there has yet to be a coordinated strategic response in addressing the youth mental health crisis that we have here in Alaska. I say that while also recognizing that there are a lot of really great efforts underway. Department of Health has wrapped up their behavioral health roadmap sessions. I'm hopeful that there will be some key solutions coming from that. The Department of Justice report that issued findings that Alaska is over-institutionalizing its children and pointing to the need for more community-based services. I'm hopeful. And the Alaska Hospital Healthcare Association and the Alaska Behavioral Health Association and others have really joined efforts to really collaborate on what they're calling a Birch model to really propose as a transformation system of care. And that is all well and great and beautiful, but we have to keep kids centered to what we're doing. There's, again, Crisis Now model, a lot of really good work going into that space. Those services only treat individuals oftentimes 13 and older. We're seeing the acuity rise in kids much earlier. I mean, having 12-year-olds come to our residential program in Eagle River is quite astonishing. And so I thank you for the opportunity to present today. Definitely open to questions and continued conversations around how we can work together.
I wanted to note that Mr. Cross joined us at 9:25. And I also wanted to ask, is it more difficult to get, is it Medicaid funding for outpatient? And is your inpatient, they're better about paying for it, or is there no difference?
It's a little bit of both. And so for our residential program, we have 2 levels of care in that program. It's an ASAM level 3.5 and an ASAM level 3.1. The ASAM level 3.5 is only $20 more than the community-based service. Takes a lot more than $20 a day to operate a residential program. The 3.1 level of care, adult 3.1, is $50 more than an adolescent 3.1. Then we're primary substance use treatment, but we're serving co-occurring kids. Over here in this other branch of Medicaid services, because they've split out SUD and mental health, even though we have co-occurring kids, over on the mental health side, adult mental health programs reimbursement is twice as much as children's residential rates. So the disparity there is paralyzing. For outpatient services, they are the same rates for adults and adolescent for community-based clinic services. So I wouldn't, none of it's easy. and all of it's necessary. I will say that the Department of Health leadership has been very receptive to having some of these challenging conversations. And again, I am hopeful. It's just very challenging when the needs are rising and the funds are decreasing, and we need action soon.
I had another question.
Yeah.
So Beggage is in my district, and
Yeah.
so that,
Great.
puts some alarm bells up. So I guess, is it that there was a suicide ideation at that age, or was there just a spike in drugs? The focus on that was a mixture of both, or what was coming into Beggage that was making it a kind of a alarming situation?
Beggage experienced several suicides within their student population. Over the course of the last 5 years, every year they have had a traumatizing event to either their student or their faculty.
I'm a little chatty hatty today. I had my coffee. I was working with a woman that is trying to tighten up the algorithms for Facebook and social media, and seeing that there's a link between suicide and what's happening on the internet. Do you feel like that's a part of the play in this a little bit, or not?
I can't say for sure. As a service provider and a mom, I do think that social media is a contributing factor to just the disparity that youth are experiencing and the level of hopelessness and suffering. Whenever we talk about loneliness, the epidemic of loneliness, like the U.S. Surgeon General called it in one of his advisories, the solution always comes back to community. And so, I think all of us in this room could probably point to the number of problems that might be contributing to this. But we all know that the solution is around community-based solutions, and community really lifting up ways to support their kids and the people who are struggling. I will say that Senator Sullivan and the Surgeon General, Dr. Murthy, they came a couple of months ago and facilitated a roundtable discussion. And there is some good energy around research into social media and how to potentially regulate those algorithms to help protect our youth.
One more question, then I'll let you. So the marijuana industry will probably be very upset with me asking this question, but with legalization, have you seen a spike in kids being involved in drugs besides marijuana? Has it opened the door for youth at all? And this is legal, so must be safe, even though we know that's not true, that things that are legal aren't necessarily safe if used wrong. Do you think is there any correlation?
I can't say with complete certainty. I have assumptions. I do think it's important that as a society, if we're legalizing marijuana, regulating it, taxing it, that's all well and fine. But you also can't ignore that continued chronic use of marijuana is damaging to a developing brain. And so there is evidence that's really pointing to the increased diagnoses of schizophrenia, especially between the adolescents who are smoking marijuana chronically.
Thank you very much for being here, and this presentation was very good.
Yeah, absolutely. Thank you.
Next, Allison Keir. I hope I'm saying that right.
Karen?
Oh.
Kevin Cross on the line. I was getting the queue.
I'm sorry, Kevin, did you have a question?
Yeah, actually, so my wife and I are licensed foster parents, and so this matter with the young adults or late teens being caught in a in this system that is unfortunately kind of not failing, but is struggling is really near and deep to my heart. And I wanted to ask, I apologize, I didn't catch your name on the phone, but who was just speaking. You know, one of the breakdowns that I see or that we've experienced is that, you know, a lot of these children who need help, you know, they need some really good counseling, and the counseling services, one, are really struggling, hard to find. But more importantly, is counseling for parents, because a lot of times, you know, there's unique issues that each child is facing, that these teenagers are going through, and it's not just counseling services for the children, but for the parents and for the families involved to make sure they're handling these. And, you know, I'm kind of curious on, you know, what efforts are being done. I mean, we could just say throw money at it, and I realize that's, you know, a big part of it, but it really comes down to the training and what training programs we're investing in, or what training programs we're seeing working, where we can direct funds appropriately to make sure that people are adequately emotionally and, you know, physically prepared for the challenges of taking in, you know, emotionally distressed children. Because that's where that recidivism, where you hear children who have been in 5 and 7 homes and in just a matter of a few years, how traumatizing that is for everybody involved, and how we stop this process of them bouncing from house to house. Thank you.
Thank you for your question. I appreciate the question. And while you were talking, I'm like, preach. Yes, because I agree with you wholeheartedly. We've expanded our family services program over the last couple of years to do exactly that, to be able to provide individual counseling services for the parents and loved ones of the kiddos that we have in care. It always baffled me before of, you know, we're serving the kid, but then we're having to refer an adult to an outside provider. And so that was one of the changes that we made internally over the last couple of years. There is a new service in the 1115 waiver called a home-based family treatment. And there's a reason why providers haven't been able to stand up this new service, and it's because the capital investment to stand it up does not exist, and the long-term sustainability with how the rates are set are too low for any provider to take a chance on it. So I wanted to mention those two things. The other piece that you mentioned about training, I think that's one of the beautiful things about the school-based programs that we've been having a lot of success in partnership with the Anchorage School District, is really walking alongside the schools and really providing family nights and trainings and pro tips in their newsletters and ways to really gravitate towards where the families and the students are, and trying to bring them in to know that support is available. I do agree with you that this needs critical investment, and maybe something I'll add to what's not covered in Medicaid, because that is not a reimbursable service. And we do, as service providers, do need to have a way of making sure these services last long-term.
Thank you. Yeah, it's interesting how we draw these lines in the sand when it comes to servicing individuals, particularly, you know, when they start off as children in broken homes or in surrounded by substance abuse, because, you know, we've placed children, and we've had children who, although they were older emotionally, were still toddlers because they haven't had the right environment to emotionally develop. And yet it's interesting because then as they become teenagers, we look at them as teenagers, but the truth is emotionally they may still be 10 or 11 years old, and they're really struggling. And so we draw these lines in the sand with our services. And I think we really need to take that perspective, because every person on the street was a traumatized child at one point, and they just never grasped how to deal with those issues. And if we don't really seriously look at how we're taking care of our youth, we will never get a handle on our homeless situation, because we're just feeding the problem with the next generation of struggling individuals. So I appreciate everything you do. Thank you.
You said it. So Allison, you want to take her away now?
Yeah, I would say note to self, never follow Julia with the PowerPoint presentation. So really, you know, I was invited down just to have a conversation about what we're experiencing at Covenant House. And exactly what Assemblyman just said, there's no young person experiencing homelessness that's not in a space of trauma. And so as an organization, Covenant House has been providing services in Anchorage for over 35 years. I started when I was 12, which was about 25 years ago. And the things that I've seen over this time, initially when we started, our average age was 13, 14. And what, as an organization, we were primarily providing services for was what was called kind of in that day a classic runaway, right? A young person running away. At the time, that was a criminal offense. Therefore, they would be picked up by, McLaughlin or juvenile justice and start a path down juvenile justice. So Covenant House, as a federation, really took on a lot of the state laws that criminalized this. And so in an effort to bring a Covenant House program to Alaska, the agreement was that they would change that so that we would work to not criminalize it, and as well provide a bit of a sanctuary for a young person to be able to remain for 45 days without, a parent or someone just literally, even in a case of neglect, being able to kind of walk in and have the young person removed. It really offered a safe sanctuary. So if you think about where we started and where we are today as an organization, our average age is 20, 21. Our use of the CARES Act dollars was really to expand our services up to age 24, as well as separate out our work with minors 13 to 17. They used to all happen on the same footprint. And as we saw the increased trauma and increased drug use, increase a lot of behaviors that we really didn't want to mix with a minor population, it was felt best that we separate. So that was a lot of the work that we have been doing, post-pandemic. And, the things that we see now, we as an organization, our focus is really to create a path for stable housing for a young person. And stable housing for a minor looks very different than stable housing for, a young adult in the 18 to 24 phase. So in that context, we have built a very robust continuum to offer multiple options for housing. So we have micro units, we have a training academy, we have transitional living programs, all the different things. But our goal is that stable housing piece. And contrary to a lot of beliefs, we're not a treatment program. And I always like to say that, we try to do what we do best and then partner for the rest, right? And so there are some amazing programs out there. And so we partner deeply with Volunteers of America. We partner with South Central Foundation. We partner with Cook Inlet Tribal Council, and all the resources that we bring together still does not adequately address what, as a community, we are facing with the fentanyl crisis as well as the mental health crisis. So we find ourselves in this perfect storm of amazing providers doing great work, but not enough resources for them to adequately do what they're capable of doing. And then you have a crisis with fentanyl in which, when we talk to young people, it's maybe a little different than a young person that is actually in a treatment program and they're kind of, space that they're really into recovery. So we talked to a young person about their fentanyl use, and it, breaks my heart because we have young people that, we used to have this belief that they just didn't know fentanyl was in the was cut with whatever they were trying. Now what the realization is for many is that they're seeking it, and they're seeking it because they feel absolutely lousy. So it's highly addictive and takes very little, and very little creates they no longer are creating a high. What's happening is that they are basically not feeling as lousy. So, when you talk about young people, taking drugs for the high, that's not been our experience with what's happening with fentanyl. They're taking it to just not feel horrible, right? And so that being said, they also, with Narcan, they have a bit of which I'm very grateful because, we're seeing 3 to 5 fentanyl overdoses a week. So that would be 3 to 5 young people that we would be losing a week if it wasn't for Narcan reversing the overdose. And so while Narcan has created a space where we have another opportunity to work with a young person, it also is such that young people will come in, they'll ask for a Narcan kit, and then they'll go use, and they'll have a Narcan kit available when, and it's not if, when someone overdoses. So it's an interesting thing that we've never seen before with having the drug that kills and the medication that revives, both in the hands of the young person making some decisions that aren't the best choices. So, we are trying to be at every table. We're not a mental health provider, and so we don't often understand the language of behavioral health. We do not receive any Medicaid reimbursement, so it is not something that is a part of even our normal operations, but yet we realize that there are amazing partners that do. But just like us, if we had the resources, more resources, create opportunities for innovation, change, all the different things, more resources for behavioral health organizations, provide them the opportunity to deliver services that save our young people. So we sit in that hand in hand and are actively looking on, regular basis. I mean, we have, we have really, and Julia can tell you, we often seek resources that we use to pay another provider to come in our space and deliver a service, knowing that Medicaid is not covering for Julia's clinicians to be in our space. We went to the Mental Health Trust and we said, we are losing kids. We are losing them. We are losing staff because our staff have signed up to, be in a environment where we're trying to help young people thrive, and they're spending their days reviving and doing CPR. And so the ability for us to retain workforce based on what our workforce sees has been quite challenging. So we go and we seek funds that are less restrictive, the private investment, and I'll say to Julia, how much will it cost for us to have a full-time clinician? And then really try to raise those dollars to help it, knowing that they're spending their time raising the dollars for all the rest of the services that they're providing as an organization. This last effort was for a clinician. And, while I would say it helps with youth interventions, it was primarily for staff. The ability to come to work every day and be engaged on the front line and needing a place. And often my workforce is very young, right? It's their first job out of college. And so I want them to be able to maintain a career in this, and to really take their heart and mission and be able to pour it into this work. So therefore, I have a full-time clinician that really spends a lot of time processing with our staff on how to continually deal with what's going on. So as an organization, I mean, we receive zero funds that we employ, that we use for mental health. We receive funds that we deploy 100% to receive mental health services. The use of fentanyl in and around our space is, the vast majority of our overdoses are within our footprint, our campus footprint, outside of our building. I talked about this the other night at our candlelight vigil. On my way to the vigil was a young person that had overdosed in a car around that block, our block. The people had brought her from the car. The person she was with brought her, dropped her off at the dumpster behind Covenant House. And I was leaving and I was watching staff call 911 and revive this person. Paramedics, everyone came, and I was heading right to the candlelight vigil. And within 45 minutes, the same person that overdosed was at our candlelight vigil. So the problem is, and that was a forced ambulance. Like, we have a policy that basically says, we don't know what you've taken. We're not a medical provider. If you overdose, you need to be medically cleared. I think there's also something to be said about our relationships with hospitals and such, that even before we can process this overdose, the person is returned to us with the thought that this person lived with us, right? Like, it was as if they were discharging to a family, and that doesn't exist around that young person. And so there's multiple systems that have gaps that young people fall between, right? And they're not little gaps, they're cliffs, right? It's the ability for that young person. So I wish that I could say to you, I have like the solution. I don't even 100% believe it's a money issue. It's the way we spend our money is an issue. And I think that, as Assemblyman Cross said, no one makes it into adult chronic homelessness that had an effective intervention as a young person. There's research, there's facts that prove it, right? And yet we continually, with limited resources, have to direct those resources to a bulk of, a greater need, yet the investment could be such that it's stopping that inflow into adult homelessness. So, I'm here as part of, the effort to say, we want to be a part of the solution. I wish that I knew exactly what to say it was. But I know it means a lot of different conversations, me in conversations at behavioral health tables that I'm never at, in the future. And Julia at conversations and homelessness, right? Like, there's just an intersection. We don't have a bench that there's 5 of us doing this work. There's 1 of us, doing this work, right? And so, without a PowerPoint, I'm just here to say we're a part of, the conversation, and to answer any questions about what our experience has been with the young people that we see and serve.
So we don't compel anybody for treatment now. Like, used to be, you could make the choice between being incarcerated because you have an illegal substance or treatment. If we were at that model, there just wouldn't be treatment available. You wouldn't have that choice because there's not enough, I believe. Or do you feel like that model could help with this situation? What do you think?
I don't know that I would say that. I don't know if it's a help or a hurt, right? I think that in the past, when there have been times that there have been a little more meat to really kind of direct someone into treatment, then we found out that we didn't have adequate treatment beds, right? There's nothing that's happened that have doubled down or increased those beds. So if we go back to that space, my fear would be that we would run back into the problem of, here I have a young person ready, and I have no place for that young person to go. So I think part of what, you know, has been just my experience is that we get a lot of traction in one area and we don't realize that all the unintended consequences of those, you almost have to figure out how you make enough of an approach on everything, right? Because it definitely, you know, if a young person comes to me today and says that they need treatment or if they're interested in treatment, you know, between a partner, we can get someone into services. And I wish that we had this plethora. One of the things that we're really trying to do more of is a lot more education and recovery services in the space. And, you know, we were talking with CITC yesterday about trying to see if we can train on a peer model that would be based in our program that would help shape. But again, there's no resources, right? So it would be, can we lift yet another thing in order to deliver something that could be a very positive on it, right? And so that's kind of where we land with it.
And I wanted to piggyback off of what Allison was saying. There's a reason why behavioral health, there are some, but there's a reason why there aren't more behavioral health providers at the table when we're talking about homelessness. And that's because we don't have mechanisms to truly provide the services and sustain them long term. I do remember when judges would require somebody go to residential treatment, and then I was at that residential treatment saying, you don't meet level of care, you know, like, and so there's been like such an evolution between, you know, kind of legal requiring treatment. And I'm so proud of the evolution of behavioral health services over the last 5 years, especially. When we say that we meet people where they are, we do. We just need a mechanism that supports it. You know, oftentimes the young people that are in Allison's programs, they are enduring so much trauma that they're not ready to trust a behavioral health professional. And so it takes time to really build that rapport and build that connection and support them through that healing journey. Without funding from the municipality, from the Alaska Mental Health Trust Authority, those resources and those initial touch points and conversations wouldn't be happening.
Thank you both for being here. This has been very interesting. Obviously, it's, you know, tough subject matter, but I appreciate your candor and sharing your experience with us. You know, this is fresh in my mind, so I just kind of I want to talk about it. Last night, the Assembly voted to overturn the mayor's vetoes on our budget amendments, and the one amendment that I spoke to from the dais last night, I said, you know, this is the one I was most surprised to see. The Assembly wanted to increase the budget for mental health, behavioral health within the alcohol tax by $100,000, and the mayor vetoed that. And in the memo, his rationale was that he said, "As I've said, I support shelter." And I just thought that was very interesting for a couple of reasons. Number one, behavioral health is not just a homeless issue. Anyone can have behavioral health issues and need to find those resources. But number two, I think, you know, it kind of gets to what I think I'm hearing from you all this morning is that, you know, shelter is part of a continuum that's needed, but also the people in shelter who've been through trauma or who have substance use disorders or behavioral health issues that haven't been met, you know, they need those resources as they're being sheltered, and that's what's going to drive positive public health outcomes. And so to hear about different providers teaming up to do that work, I think that's encouraging to me, despite some of the tough stuff that you're sharing. And so I don't know, I think the Assembly again and again has tried to make that more of a priority and also have a better balance between the various buckets of the alcohol tax fund. And we're doing some work right now to try to make that process easier for various community partners. Yeah, the other, so that $100,000, what we wanted to increase was sort of a case management response, where it was part of the complex behavioral health task force that the assembly convened. One of their recommendations was we should have medical providers be able to go on site, where we know that there's a need, whether that's in transitional or supportive housing, or if that's in shelter, or if that's where people are camping. And there are folks in the community who are doing that type of work, folks like Mountain View Health Clinic, or South Central Foundation, or others, but where providers can go and they can do telemedicine, or they can help make sure that people are on their medications. If somebody needs a ride to a doctor's visit, or to I don't know, a VOA event or something, that you got a camp, or so anyway, I guess I'm don't want to ramble on too much, but I just think as we move forward as the Health Policy Committee, and we're trying to have some input into some of these funding decisions, with the limited resources, frankly, that the municipality has to fund these things, I want to keep front of mind that the behavioral health, the substance abuse treatment is equally important, as is people having a safe place to live. So those are my thoughts. Thank you.
Mr. Cross, did you have anything? I know you don't have my number to text.
I'm good, thank you.
Thank you both for being here. Appreciate it. And and Mr. Salt has just joined us. Thank you. All right. We are going to move on to the Health Department, and I know that Annie Thomas Landrum, is that you? Is going to present, because Director Rash has a previous commitment, and Dr. Savitt is also here. So please come on up, and we're going to have a little bit of the Health Department data. We're going to talk about impact of short staffing and what that's doing with the Health Department, and a little bit about work environment. And I appreciate you being here.
Good morning. As noted, Director Rash is at another meeting right now. I will be presenting some of her report. She has asked that any questions as a result of the report be directed to her in writing, so that she may have a chance to respond. So I'm going to keep it brief. So I'll start out with the report itself, some key points. The Health Department has used social media to advertise the Health Department's participation in Volunteers of America, Alaska Fall Festival, the Alaska Public Media Mental Health Resource Fair, and the Alaska Federation of Natives Convention. Other posts included holiday closure notices, celebrating the completion of the Protected Bike Lane project, People Movers virtual open house, AHD's flu vaccine clinic, pedestrian safety month, food safety, the Change the Anchorage Safety Patrol, the emergency cold weather shelter plan, alcohol tax, early childhood education grantees, ADRC assistive technology, vaccinations, a call for members of the implementation team for the Anchorage Child Care and Early Education Fund, Breast Cancer Awareness Month, DEA drug take back, and Halloween. Our public information officer began updating the MOA's COVID response website, coordinated with the Legislative Service communication coordinator to send out a joint press release seeking parent and provider members for the Anchorage Child Care and Early Education Implementation Team. The Anchorage Opioid Task Force met in mid-October, and participants discussed ways for the task force to involve more people in Anchorage, including brainstorming a community engagement plan and existing events that the Anchorage Opioid Task Force should table at. Customer service, clinical closures are based on operational capacity and needs. All closures are noticed to the public via building signage, calling clients to reschedule if necessary, social media and website updates, and done in advance are changes to the normal operating hours. So those are some of the highlights. I'm going to add a couple things to that. We are also participating in the National Influenza Vaccination Week with the state section of epidemiology. It's important to note some of these things. COVID is not gone, although it seems to be largely forgotten by many folks. For those of you who follow what subvariants are dominating, HV.1 at 29% of the population, EG.5, which had been dominant, now down to 21.7%. FL.1, 0.5, 0.1 at 9.3%. So the bottom line is that it is around, it's the respiratory season. So we have flu, we have RSV, we have many of the para-influenzas, adeno, we have all kinds of viruses that we're subject to. And the same prevention measures are recommended. It's not too late to have your flu vaccination. It's not too late to have your COVID booster, COVID boosters, COVID vaccinations, I should say, are still the first line of defense against COVID. They prevent severity of disease, hospitalization, and death. So it's important to take that vaccination, especially if you are in one of the higher risk groups for that. Also, I know there's been a lot of controversy surrounding masks. I will reiterate what I have always said about masks. They serve a purpose, but cloth masks, medical surgical masks are of limited use. If you look at the studies done, they're good for about 30 minutes above no mask at all. The KN95 masks, again, much better, good for about 3 to 4 hours. And then the 95 masks are good for around 23, 24 hours. In addition, proper handling of those masks is still essential. Distancing is helpful. Hand washing is always helpful. And room air ventilation, very, very important. And I've said this time and time again, and I'm just going to repeat it for the benefit of those folks who are listening. I'd like to take this opportunity to introduce Annie Thomas Landrum. She's going to give a presentation, which I think you'll find enlightening.
Dr. Savick, can you clear up, or is this a Kim Rash question? So I had sent her a message that came through a constituent that was given it says here there's closures based on operational capacity or needs. And she was told she could not get the next shot in a series of vaccinations, that from now on you need to go to urgent care or senior care. So that's not true. That was just like a blip of closure, and you actually have enough staff
I can tell you that that is not the case. I don't know where that information was coming from. I can tell you that we have a wide range of vaccinations from early childhood right up to the senior population. I can tell you that a couple of weeks ago, we had our health fair at the Senior Activity Center. And despite the bad weather conditions, we had an impressive turnout. We gave vaccinations to seniors. We gave a lot of COVID and flu. We gave shingles. We gave a lot of vaccinations. There were folks that had come over to the health department who had not made an appointment. They were walk-ins, did not know that we had moved our clinic activities over to the health center for that day. We did have some signage. We did have a person there, our security guard, who was giving this information. Some folks chose to go over to the activity center. We had one individual who brought her child. We were able, even though it was a senior event, we still had childhood vaccinations on hand and were able to vaccinate this young man, as well as mom getting a COVID and flu vaccination. We are not turning anybody away. We happened to have a power outage and the internet was down that day. Aside from the clinic being moved over, the clinic was open. It was just at a different location. At that same event, I'll also mention we were doing STI testing, tuberculosis testing, HIV testing. There were educational sessions. We had community partners there doing hearing and vision screenings and all kinds of safety information. So I don't know where that information came from, but I would like to be sure folks know that we don't turn anybody away for any reason. If the clinic's closed on a Saturday or a Sunday or after our clinic hours, that's another story.
Thank you so much, Dr. Savitt, and I'm excited to be here to speak with you guys about the work we've been doing at AHD. My name is Annie Thomas Landrum, and I am a nurse. I've been a nurse for about 20 years. I'm a third-generation nurse, and I have a master's degree in nursing leadership and administration. About 5 years ago, after working through my career for quite a while, I was the head of a hospital that treats PTSD and found myself in need of PTSD treatment myself because of the way I had approached my profession as kind of a superhuman helper instead of a human helper. And out of that experience, I started a business called Managing Me Enterprises that works with organizations on employee retention, systems change, all those kinds of things that just make systems better for humans to work in, for our helping professionals. And I've had the honor of working with AHD for the last 18 months. And I also have the honor of working with ASD, as well as a couple of our local hospitals and other area organizations. So the work with AHD started in August of 2022, just 2 weeks after the former director departed. I went in and got to meet with executive leadership at that time to talk about what the department might need to recover after a hard couple of years. It had been hard for a number of reasons for everyone in all helping professions. And of course, the department had experienced its own difficult circumstances recently. And so we spent some time brainstorming and looking at what can we do to support the staff and to bring a holistically healthy culture that's experienced as healthy on multiple levels of the organization. And we started by doing debriefings with the staff to just give them a place to listen, to be heard, and to share what their experiences has been, to talk with each other, to just have space. We were able to do this because of a grant through the state of Alaska Division of Public Health in partnership with the University of Alaska Anchorage, AHEC. And we at that time kind of got an initial list of concerns and sort of did an initial assessment of where everybody was. And we noted that there were some pretty specific challenges that we wanted to focus on. There was widespread burnout among staff throughout the department, primarily reported as being related to executive leadership instability and the resulting impact on staff morale, as well as the impact that instability had on relationships with the community the department serves. There was a wide employee service gap, with members primarily either being in the department for a very long time, 10 or more years, or being extremely new to the department, 1 year or less, with very few employees being employed on the team for the median amount of time, 2 to 9 years. Our team has noted, just as we've worked throughout the state and in other areas, that a lot of times when you don't have this median number of years in service, it indicates a culture that is not able to retain new employees, and so is experienced as unhealthy by those who are in service. There was a high degree of siloing and mistrust between team members, especially between team members towards executive leadership, resulting from the experiences of the past several years. And additionally, there were grave concerns over the newness of the entire executive leadership team, with the most tenured leader, Dr. Savitt, being in his position for about a year at that time. There was discouragement and difficulty believing in the real possibility of increasing department health due to widespread burnout and a lack of follow-through experienced in previous change initiatives. And there was a widespread felt experience of being unseen and unheard, both within and without the department, a sense of being unable to serve the community in ways that were congruent with the passion and vision of the public health servants serving in the community within AHD. And I think that throughout our healthcare system and helping professions, this was a very widespread experience, but that the health department felt it in ways that were very poignant to them. There was also a collective sense of need and non-investment in the health and well-being of the team, experienced in a variety of ways, but especially experienced in the condition of the building and parking lots, availability of opportunities and services to staff, and a felt lack of mutual respect between team members and leadership. But we also found a tremendous amount of strength as we talked to the team. Most notably, a deep and abiding commitment to the health of the community at every level, at every position within the department, a willingness to engage and try to make things better despite the fears and the misgivings over how successful those events were going to be. An executive leadership team who was willing to listen and face the real challenges, have hard conversations, and who acknowledged their newness to the department and the learning and growing that needed to take place as a result. There was a dogged pursuit of excellence and a desire to continually learn and grow within the team members throughout the department. There was an amazing wealth of knowledge and expertise, a desire to build collaborations and partnerships that allowed that knowledge and expertise to benefit the municipality and the state as a whole. And there was so much creativity and willingness to work within existent realities to get the job done every day, regardless of the challenges faced. So in that first year, the major challenges that we identified as most commonly occurring within the staff as a whole department were environment and safety concerns, and being able to bring leaders, especially the new executive leaders, up to speed on what it is the department does and how it functions. And so those were the areas that we really focused on. In that first year, we did see some successes. There was some restructuring within the department that created a new division that allowed for better team support. Kim Rash did team interviews with team members throughout the building, writing up and publishing within the department little overviews of those roles, and allowing that to have kind of a historic impact in that when people come in to the organization, they're able to look at those interviews that were done. And it was also a way to decrease siloing and increase executive leadership and team member rapport. There were new processes put in place for facility requests that yielded a variety of improvements. There was ongoing projects to address additional facility needs, and there was increased security measures, including new security cameras and the hiring of an additional guard. And that was all wonderful. We did, however, note that because of the complexity of a lot of the challenges that we undertook that first year, there, especially with those things that involved a lot of movement outside of the department itself, there was not able to be the amount of movement on the initiatives that we hoped for, just based on, again, a whole host of complexities that just exist in any system. And that we recognize that the biggest challenges that could impact team health and wellness would be centered on projects that primarily could be controlled within the locus of control of the department itself and those teams. So as a result of those observations and work with the executive team, we decided to pivot the work that we were doing for this new state fiscal year starting in July to focus on what can we do within the department and within the programs themselves. It should be noted that though the funding available for work with teams throughout the state through the Division of Public Health was more limited this year than it was last year, just based on federal funding. The state did prioritize, because of the value that they have for the relationship with Anchorage Health Department. They did prioritize continuing that work through and funding it through currently June of 2024, so the end of the state fiscal year. So as we came back, we started looking at just what are the expectations of change that we can establish for ourselves, for the team, for the community? Because when you have an unhealthy culture, it is a wily beast. Most of my work is based in something called relational leadership theory. And that says that the truth of an organization, while it's wonderful we have missions and visions and all of those things, the real truth of the organization is found in the people that make up those organizations and the interactions between them. And so our healthcare systems, or our helping profession and systems in general, are really more like living organisms than machines. And so the people are the cells, the teams are the tissues, the organizations are the organs, and the entire system is the organism. And when you look at it that way, it's easy to see why it's interaction after interaction after interaction at a whole host of levels that creates system challenges. And so you have to be able to act at all of those levels in order to bring true systems change. So it takes a lot of time. So just looking at a quick just looking at some insights from research and reasonable conclusions that could be drawn from that. It's been noted that in toxic cultures, employees spread negative feelings among other co-workers. And from reading that literature, it was reasonable to conclude that the power of negative voices decreases as there is growing health within the organization. Employee well-being increases employee engagement, which seems like an obvious, but is backed up with the research. And it can be concluded that as engagement increases, employee well-being is actively growing. Organizational support increases a sense of employee belonging. And so as the employees are feeling more supported, they express stronger and growing senses of that belonging. When the issues are addressed with the leadership, eventually the team issues will be flushed out too. And once the team has experienced unhealth, things don't get better on their own. And there has to be an active process of walking back to health. Leadership behaviors directly impact the emergence of positive, healthy employee behaviors. And in toxic environments, there's a high degree of employee silence driven by fear and learned helplessness. The silence has a very negative impact on an organization's effectiveness. And therefore, as we see that employees are able to be empowered to use their voices, fear is decreasing and safety is increasing. Negative attitudes within senior leadership towards employee comments tend to increase employee silence, and healthy leadership encourages openness, including feedback that is difficult to hear. A felt experience of decreasing consequences for speaking up is likely to result in more employee input and engagement. And middle managers really especially experience the weight of organizational change due to the role as bridge between executive leadership and the rest of the team that they play, and the way that they unify vision for the organization. In cultures that have experienced dysfunction, it's going to be necessary to have additional steps to get outcomes that used to be pretty simple. And then it's going to take time and resources. And at the same time, we'll probably see decreased effectiveness of those organizational actions for a time as the culture heals. And when an organization makes efforts to invest in staff, even when all the efforts don't yield exactly the desired results, the care and concern significantly helps the organization recover. From this, we kind of created some reasonable expectations. While it's difficult to find research that will commit to a specific timeframe for recovery of an unhealthy work environment, it's clear from all the research we've looked at, in every case, it takes time, hard work, and consistency to do it. Because of powerful and long-lasting impacts of negative work experiences and the ways that humans go into flight, fight, or freeze, it's very common for attrition related to unhealthy work environments to continue for quite some time as people process at their own speeds. The real change that can be made starts with the executive and middle management, and as these organizational levels become healthy, there's health throughout the organization in increasing levels. It takes a long time to find the right leaders for each team, as team dynamics, needs, generational span, personality, expectations all experience hyperdrive after organizational trauma. Therefore, filling positions can take longer than anyone would like, but the additional time ensures that the team has long-term employee retention. And once the right leaders are in place and feel secure in their roles, especially middle managers, it takes time for them to build a trust and rapport with the team that allows for long-term productivity gains. Establishing a sense of safety and stability is key. So with that in mind, looking at where we've come out and where we have seen improvements currently for the department, the staff continues to exhibit a high degree of willingness to speak out about concerns, engage with issues, have difficult conversations, and remain mentally and emotionally present, which indicates that there is an increasing level of safety within the organization. There's increased communication between executive leadership and team members, with a marked increase in transparency of executive leadership efforts on behalf of the team and a resulting increase in trust between leaders and staff. There's been a consistent commitment on the part of leadership to invest in the well-being of staff, as demonstrated by their consistent engagement in the project our team has undertaken and setting aside time to meet with our team on a monthly basis for the last 18 months. This commitment has extended to middle managers and employees themselves. There's a sense of growing stability for more and more middle managers, as a tendency towards positive attrition is really taking place, and where there's been, when I say positive attrition, sometimes there's mismatches within an organization. So there's negative attrition and there's positive. And so more and more of the attrition that is being seen is about the right fit for that person at that time, which is positive for the organization as well. There's a sense of openness and transparency support between executive leadership and middle managers that's feeding hope for the future and a belief in the ability to effectively manage positive change. There's been a growing sense of safety and stability within the team themselves, as the supervisors are increasingly better matched to the unique needs of each program. And there's a demonstrated focus by staff on working on initiatives that can directly be influenced by them to bring change within their own programs. We've seen a decrease in negativity and an increasing focus on positive forward movement. And there's been a desire for strategic planning and space to create vision for the future, indicating an increase in employee engagement, investment, and leadership responsiveness through a desire to that desire through the initiation of strategic planning with a trained facilitator. There's also an active and stable sense of belonging and commitment to the organization in the majority of employees we meet with. Currently, our team has been meeting with each program to develop ways that we can help them to standardize processes, optimize onboarding, build communication and collaborations. And then throughout the department, we recognized 3 primary areas that were department-wide initiatives that we could work on. The first is a leadership series of training seminars for middle managers that started yesterday and will continue for the next 6 months. I was really excited, like on a personal note, these were some of my favorite sessions I've done recently. There was a feeling of hopefulness and excitement about building in that and having these groups of leaders come together specifically to increase their toolbox of skills. And there was a very widespread expressions of hope and hopefulness based on the support that they had received from the executive leadership team, especially Interim Director Rash, and then also from the cohesion that they were finding within their teams and the personality matches that were being described between the team needs and the leaders that were in those positions. So that's the first thing. The second thing is we're doing quarterly wellness events. We're actually at this moment doing a holiday wellness event for the staff and investing in some fun, rejuvenating time for them on a quarterly basis. And finally, we're doing coffee hours once a month just to provide, the staff has said that just having a place to come and to talk about what they're struggling with, to be heard and to understand that they're not alone has been really helpful. And so there is going to be, starting in January, a standing coffee hour where they can find that support. On an ongoing basis, we really feel that for the improvements that we're seeing to continue, being able to continue the project beyond the 30th of June 2024, to allow the initiatives to continue is really important. Increased partnership with the department leadership to publicly elevate the amazing work the team is doing within the community and responsiveness to the resource needs they are requesting to continue that work is super important. And finally, the installation of a permanent director for the department that can build on the incredibly strong foundation that interim director Rash has built, and who can, like Kim, deeply connect with the passion and investment of the current team and cultivate a vision for the future that all team members can feel really committed to. So thank you for the time to present, and I'm happy to take any questions.
Mr. Voland is in the queue.
Thank you for this presentation. I'm curious about how the assembly can be supportive. One thing that jumped out at me was page 3 of your report that talked about conditions of the building and parking lot and opportunities for staff. So obviously a lot of your work is targeted toward leadership within the executive branch. But I guess I would be curious, as you continue to do your work, if there would be maybe opportunity, if this is in the scope of your project, maybe opportunity for us to get a report of like 5 takeaways or something that
Absolutely.
how the assembly could support the health department.
Be happy to do that.
Cool.
Absolutely.
Awesome.
For sure.
I wanted to check in and see if there's any members of the public that are going to want to speak so we can figure out how to budget our time. I had one more question. So when you spoke about the building, I thought about, I have a friend who's a police officer, and she talks about how her car is her office. And when she's driving around this old beater, she does not feel appreciated. And, you know, there's a different look that the community has when, and I feel like the health department building, when I've been in there, it's shabby. And, you know, maybe I talked one time with Alexis Johnson about it, and we were thinking about the BP building, you know, if we could relocate the health department to a building that has a little more pride in it. I don't know.
That would be lovely. Honestly, the number one thing that came up within all of the challenges that we listed for all of the participants within those initial sessions were environment and safety based, and having a building that they could be proud of and that really served their needs and could kind of feed their passion and the level of excellence they bring was critically important to them. And so if there's anything that the assembly can do to make that happen, I think it would go miles to showing appreciation for the staff that stayed and retaining new staff that are coming on.
It's really interesting to know that this was going on, and I'm really glad you're here to let us know that you've been working with the health department. And I know they do great things in the community, and I really hope that we can continue to foster that and build that team back up. So thank you so much.
Thank you so much.
And I know you. I was one of your contact tracers.
That's so fun.
Dr. Savitt, did you have anything else you wanted to add, or?
Well, if we're talking about a new building, we are cramped. It's not just the appearance of the building, but we are cramped in the office spaces. We have a limited amount of space for our clinic area. We would love to be able to expand services in the clinic area, but we don't have the current capacity to do that. Staffing, of course, is still an issue. We are down to 21.7% vacancy, where it was up in the 30s not that long ago. Unfortunately, the clinic staff is still probably in the higher vacancy area. Moving on to Anchorage Safety Center Patrol. As you all know, that it's to provide safe shelter for individuals who are incapacitated by substance misuse, 365 days a year, 24 hours a day. Intakes were 606, responded to 996 calls, 434 folks were transported, and there were 378 unduplicated clients. And that would be individuals utilizing services more than once, creating that 606 total intakes, multiple visits. I'm going to assume that everyone's had a chance to read through this report. So,
Dr. Savitt, before you move on, I think Member Cross had a question, wanted to get in the queue.
sure.
No, he can wrap up. I'll just finish at the end. Thank you.
Okay. So a lot of these are basically numbers reporting in. And I'm going to, in the interest of time, suggest that if there are any questions to any other parts of the report, to please direct those either to Kim Rash or myself.
I always appreciate all the data that is put together and how nicely it's done. And we are now having these available off of the Health Policy Committee page website. So we can look at those later, and I appreciate you bringing them. And now, Mr. Cross?
Yeah, thank you. I just wanted to just give praises and kudos for the individuals working within the health department to create a better, more synergetic environment that employees love. I've seen corporations, and I've been part of businesses that had hundreds of employees, and then over a course of only 18 to 24 months, because of a lack of trust and then an avoidance of healthy conflict, which is just being able to express your opinions in a safe environment. Just watch those companies crumble. And it was, and then people start building separate agendas, and then basically they're only there for the paycheck. There's no commitment to a bigger vision. So, if you're ever interested, there's a book called 5 Dysfunctions of a Team, which is like a quick synopsis of everything she spoke to. But it's really powerful because everything that they've said there, I've seen it play out tragically in real life. And I've also seen the opposite of how long it takes. It takes a long time, and you can't really quantify what it takes to rebuild trust in the organization. There's not a Band-Aid for it. It just takes time and the right people. And so kudos for everything that they're doing. It's profound, and just how much I appreciate what they're doing. And I guess as far as Anvil, what can the assembly do? My experience has been looking at this is that the assembly sets almost an emotional thermostat. And that is that we are the public perception of what government is. And I think that's why it's so important that although we have differentiating opinions, that we're highly respectful of each other and that we behave like adults in all aspects when we're in front of the public, because we are a reflection on those individuals that we serve. And I think that's one of the biggest things that we can do, because we have healthy conflict. We don't always agree, but I'm really impressed by our process. But if we don't behave like adults, that unfortunately reflects negatively on the employees of the municipality. And I think as an assembly, we set a profound example. And I think that's part of our big role in this. So thank you.
One thought that I have, I don't know how many assembly members have had an opportunity to take a tour of the health department. So given enough lead time, because I would want it not to be overly disruptive to the work of the health department, but I wonder if there might be an opportunity in the future for the health policy committee, instead of having our meeting here, we could have a publicly noticed tour of the Anchorage Health Department and get to see some of the conditions of the building and see where people are working and learn more about what the employees are doing in the different parts of the department.
That sounds really exciting. I would defer to Interim Director Rash and to Dr. Savitt and the rest of the leaders, but our team would do everything that we could to support that. And from my perspective, talking to members of the team, I think that would be very encouraging to them to feel seen.
I've actually invited members of the assembly to the health department on a number of occasions, and the invitation is open-ended. Anytime you or any other members of the public would like to come to the health department to learn more about what we do for the public, if you would like to join us on some of our outreaches to see what those consist of and how we're not only operating within the confines of our physical plant, but to be out in the community to get to those folks who are unable to come in to see us. You're more than welcome to join us in or out of the building. We welcome the chance to show you what we do.
Thank you so much. And thank you both for being here. We are out of time, so we are going to need to adjourn.